Well, you all know why we're here and what we're talking about. I'm Jeremy. I'm going to be talking about telehealth law. This is a disclaimer that we throw up there. Today, you're going to have a really great, I think, succinct presentation on a whole range of elements of healthcare law and specifically telemedicine law. I'm going to do an introduction on sort of general trends that we're seeing in the field before we'll move actually to number 4. Amy's going to talk about fraud and abuse issues, then Dave will talk about New York regulatory considerations, and Stacy will talk about privacy. I get this question a lot because lawyers are annoying, a lot of people don't like dealing with us, and clinicians are really busy. So why should you care about telehealth law point blank? And the reason is that it's changing and it's evolving. And as telemedicine evolves, the practice of medicine is evolving. And as the practice of medicine is evolving, your responsibilities as clinicians are evolving and standards of care are changing. And when that's the case, and as the standard of care moves along to incorporate telemedicine, you'll then be expected to use telehealth technologies and provide services via telemedicine in a clinically competent way. And this is an area where there is some risk involved. We can't tell you that there isn't because, like anything else that clinicians do, when providing services, you need to provide these services in a clinically competent way. But if you do that diligence and you do your background and you think about these issues that we're going to talk about, there are also tremendous rewards that are on the table for clinicians who embrace telemedicine, learn how to use this technology, and improve the services that they're providing in the process, and frankly, provide things that some other clinicians may not be willing to do or able to do because they haven't embraced the technology in the same way. There are a lot of issues that need to be vetted on a state-by-state basis. As most of you, I suspect, already know, medicine is regulated on a state-by-state basis. Dave is going to talk more about that in his portion, but what I really want to underscore is that even for folks who've been practicing for, say, 25 years here in New York, now moving into telemedicine, providing services that way, the second that you are providing services to a patient who's located in another state, for instance, just somebody who's fairly close by in New Jersey or Connecticut, or somebody who's in Alaska, it doesn't really make a difference. The law of the state in which the patient is located is going to govern. So the second that you start providing services to someone located elsewhere, the standards that you're familiar with in New York no longer apply. And so you need to make sure that when providing those services, even if you're providing the same exam that you've given thousands of times over decades, you need to make sure that state law with regard to, for instance, something like licensure, do I need to be licensed in the state of New Jersey in order to provide services there? Things like that need to be vetted, and it's important to appreciate and vet those issues. Another area, and excuse me, before I move on, one thing I wanted to note is that the trend on state-by-state issues, those regulatory issues I was just talking about, generally the trend is that the industry is moving towards a set of sort of standard provisions. There are still some differences, but for instance, in virtually every state at this point, if you're providing care utilizing a live, synchronous, two-way audio-video communication, which is a fancy way of saying Skype or FaceTime, you will be deemed to have established a physician-patient relationship. Again, that's the vast majority of the time, and you need to look at each specific state's law. But we are moving towards some uniform standards, but we're not all the way there yet, so it's still important to think about them. Medicare has traditionally, and particularly in an environment like this, everybody here knows that Medicare reimbursement is tremendously important to hospitals and other healthcare provider institutions. Medicare hasn't paid for very much historically in terms of telemedicine, and the reason for that is that historically Medicare has looked at telemedicine as a really great tool to provide care to folks in rural areas, folks who have those sort of barriers to accessing care. But that hasn't really kept up with the way that the role that telemedicine really has in the practice of medicine today. A lot of the most sophisticated institutions in the country are relying heavily on telemedicine. And the Medicare program has slowly moved along, and in the physician fee schedule proposed rule this year, we got our first sort of inkling that there may be real change coming, and I think that this is also in Dave's presentation, so I won't spend too much time on it, but it does look like we are slowly moving into the future when it comes to Medicare reimbursement, and that I think is something to be excited about, because again, these are not earth-shattering technologies that we're talking about, and these are things that the majority of clinicians, I would venture, are already using in their practices. This just means that Medicare is finally going to actually provide some compensation for them. Now, and it was, the last presenter, thank you for bringing up the opioid crisis right at the very end. That was very helpful for my presentation. A big topic in telemedicine lately has been the opioid crisis. And the reason for that is that Medicare reimbursement restrictions on telemedicine services for a long time have stopped clinicians from prescribing opioids via telemedicine without a prior in-person evaluation. And the reason why that's the case actually has nothing to do with opioids, but in the late 90s, there was, I'm sure many of you remember, there was a whole episode in healthcare in this country where there were sort of pill mills running around and folks were being prescribed controlled substances without ever having any sort of meaningful evaluation from a clinician. They were really filling out a survey, submitting it, being prescribed their Adderall or whatever else it was they wanted, and that obviously was a problem. So a law was passed that said that you couldn't prescribe controlled substances as a clinician without a prior in-person examination. Great. At the time, nobody was thinking about the opioid epidemic. Nobody had that crystal ball. And in the last couple of years, this presented a real problem for folks, particularly in more rural areas, who were trying to respond to this real epidemic. Some of the areas that were really ravaged by the opioid crisis are really rural states where it would have been really, really helpful to have clinicians providing this treatment and prescribing drugs via telemedicine and things that patients really needed. But because of the Ryan-Haight Act, this wasn't possible. And this is actually this is an example of patient care and clinical considerations really winning out because, as I suspect most of you are aware, Congress recently passed and the President signed into law a compromise sort of package of opioid legislation, and we're not entirely sure what that is going to mean in the telemedicine context, except that there will be Congress and the President have directed the DEA to create a process whereby clinicians can register with the DEA and get permission to prescribe opioids via telemedicine. That's not a new idea. It's actually something that the DEA committed to doing almost a decade ago, but hadn't happened. So Congress stepped in and really imposed, I guess, this requirement upon them now. And I think that this is another area where if you are able to, if you're working in an area where this is relevant, if you're able to get comfortable with that technology, it really, forget rewards for clinicians aside from doing your job really well and treating your patients well, this is an advance that will make a big difference. And so this, I think, is a win from a patient quality of care perspective and from a telehealth advocacy perspective. The last thing I'll talk about is telemedicine enforcement activity. And as we're seeing the utilization of telemedicine continue to grow and more money is pouring into it, there's going to be more and more scrutiny from state and federal actors and private actors alike. The good news right now is that we haven't really seen much enforcement activity yet. The bad news is that it's almost certainly coming. In 2018, earlier in the year, HHS-OIG, the Department of Health and Human Services Office of Inspector General, issued a report, and they did a review, an audit, and they found that 70%, nearly, I think it was 68%, but a huge chunk of the claims that they had reimbursed for services that were provided via telemedicine were inadequate in the way that they were submitted. I think specifically most of them failed to meet Medicare's geographic originating site requirements. So patients weren't located at the particular categories of facilities and in particular areas, HIPSA's health professional shortage areas where they were supposed to be to have these services paid for. What does that mean? It means that HHS-OIG, as a federal enforcement entity, is looking at telemedicine. Now, in addition to federal enforcement concerns, you also have to look to state-level actors. In addition to the federal Medicare program, each state Medicaid program has its own Medicaid fraud control unit, and they often take direction from HHS-OIG, which is a large federal actor. And so it wouldn't be at all surprising to see increased enforcement activity really scrutinizing telemedicine arrangements on the state level through these state Medicaid programs. And then finally, private payers, where actually there are more services being provided and paid for via telemedicine than anywhere else at this point. None of this has been formally initiated, but I am aware of several large national insurers who are looking into this. And the reason why is that they think that they're effectively being defrauded. They think that clinicians are providing, say, one screen, or they're looking at photos for the dermatologist is looking at photos, and they're providing that one examination that way, and then they're billing for it 5 times. And so this is something that we don't know exactly how, but is likely to be coming down the pike. And so again, this is just to underscore that it is really critically important for clinicians to just pay attention to these issues and do your due diligence, and also make sure that when you're working at a hospital facility or at a clinic, or if you're working with a telemedicine services provider or whomever it is, speak with them about the legal issues and make sure that they are appropriately vetting these issues as well. Obviously, I don't think that there's a problem given this entire presentation and this entire day here at Stony Brook, but more broadly, it's really important to make sure that they're aware of all of these different legal issues, and that they are doing their part in making sure that you're taken care of as well. And so long as that's the case, I really believe that this is an area where there's tremendous opportunity for physicians and other clinicians, and it's a really exciting time to be involved in medicine. So that is all that I have, and I'll turn it over to Amy now to talk about fraud and abuse.